A very warm welcome. I am Dr. Masood Khan. Today, our topic of discussion is hyperthyroidism and thyrotoxicosis. The command given by the examiner is examine the thyroid gland and relevance or show me the thyroid status. Presentation of a case is thyroid gland is diffusely enlarged or nodular 7 into 6 centimeter, non-tender, fine in consistency, freely mobile, no retrosternal extension, no palpable lymph node. Bruit is present. The patient has tremor of outstretched hands. Palms of the hands are warm and sweaty. Pulse 120 per minute. Pulse may be normal if the patient is on beta blocker. My diagnosis is diffuse goiter with thyrotoxicosis. There are certain questions, like there may be atrial fibrillations, ectopics, and high volume pulse in thyrotoxicosis. Examiner may ask, what else do you want to examine? Well, I would like to examine the eye, cardiovascular system, and jerks of the outstretched hands. Now, what do you think the cause of thyrotoxicosis in this case? In young patient with diffuse goiter and exophthalmos, the likely cause is Graves' disease. Even if no exophthalmos, still it can be Graves'. In middle age with nodular goiter, single or multiple, the likely cause is toxic nodular or toxic multinodular goiter. Causes of thyrotoxicosis. What are the most common causes of thyrotoxicosis? Graves' disease is the most common cause, 76%. Toxic multinodular goiter, 14%. Toxic nodular goiter, 5%. The toxic adenoma or hot nodule called Plumer's disease. Thyroiditis, subacute thyroiditis, also called de Quervain's thyroiditis, and postpartum thyroiditis, all are transient. That is, there is a transient phase of thyrotoxicosis. Hashimoto thyroiditis, initially it's thyrotoxicosis, but later hypothyroid develops. Fictitious thyrotoxicosis, self-intake of thyroxine. Iodine-induced thyrotoxicosis, that is Jod-Basedow phenomena, and drug like amiodarone-induced thyrotoxicosis. Others include the follicular carcinoma of thyroid, stroma overi, identiform mole, and choriocarcinoma. Both secrete thyroid-stimulating hormones. Now, what other questions in history would you like to take in case of thyrotoxicosis? The question is, do you prefer hot or cold? Do you have excessive sweating? The weight loss is very common. Appetite is increased in thyrotoxicosis. The bowel present as diarrhea. And in female, usually amenorrhea is present in thyrotoxicosis, along with palpitation, tremor, irritability, insomnia, anxiousness, or nervousness. In any patient complain of loss of weight despite good appetite, the likely diagnosis is thyrotoxicosis. Other cause may be diabetes mellitus. However, loss of appetite is thyrotoxicosis may occur in the elderly. Investigations For thyrotoxicosis is radioactive iodine uptake test at 2 hour, 4 hour and 24 hour. There is increased uptake and rapid fall after 48 hours. Thyroid scanning, technetium scintigraphy is better than radioactive iodine uptake test because it is quicker and requires low dose of radioactivity. Ultrasonography of the neck to see single and multinodular diffuse goiter. The FT3, FT4 and TSH, they are very important for thyrotoxicosis, like low TSH and raised FT3 and FT4. While in T3 toxicosis, T3 is high, but TSH and T4 is normal or near normal. Thank you very much.